It's May 23rd in Grand Forks here at the Boundary Hospital. The Interior Health Board was here today to meet local citizens and media. Christine Thompson, former city councillor and city employee, was speaking for the group, and she had a list of 13 questions to ask the board. I'm going to show you that in just a second. Quite a few people showed up. Pretty much the boardroom was packed. Let's see what they had to ask, and what did the board answer?
Well, ladies and gentlemen, I'd like to thank you all for taking the time to come. As you know, this meeting was put together with tight time constraints because we're meeting with a lot of groups. We've met with the physicians, the staff, the auxiliaries. We had a heliport opening event here a little while ago. There was lots of excitement there. We may not be able to. We've asked Christine, who's I think your spokesperson. So, in the interest of time, for you to ask the questions or make comments or whatever you have, I assure you we are interested in hearing your concerns. In many communities, and we're going to ask you in the future, if you could, to funnel your energy and stuff through the all of this collective energy that you put together through your elected local representatives, because that's their job, right? Is to get that community. We can deal with them, but that's for another day, because it's very difficult to put all the groups together into a very tight schedule. We get here so well, we try to get here once a year. Okay? We've been successful in doing that. We may not have answers to all your questions today, but we are taking notes. Jamie Brayman from Dr. Halpenny's office is there. To my right is Dr. Halpenny, who is our CEO, president and CEO. Ingrid Hamp, that many of you or most of you will know or should know, who lives here in your community and is our area director, and our vice president of acute care services, Alan Sinclair, just to my far right. I think that sets the stage. I don't want to take.
Sorry.
I'm sorry, I'm Norman Embry. I am
okay.
the chair of the board of Interior Health. Yes, you're right. I live in Salmon Arm, and Dr. Halpenny and I try and get around to meet as many people as we can. As you probably know, we cover a big area, 215,000 square kilometers, 740,000 population sprinkled all over that, and we have 22 hospitals and another probably 12 or 13 community care facilities. So it's a pretty broad number for us. Thank you for asking. I don't know why self-deprecating. So Christine, if you would.
Okay, thank you. We have 13 questions that we hope to be able to get through in our time. So the first one is, prefaced with, our community is disappointed that IHA has not availed itself of the investment and commitment by Rod Gustafson in the development of the Broad Acres Care Facility. Have the two of you had the opportunity to tour this facility? And if not, why not?
No, I haven't toured the facility, and it wasn't on our list of places to go.
Could you speak up a little louder, because it's difficult to hear back here?
Yeah.
Thank
So
you.
simple answer is no, I haven't toured the facility. Again, it's a private facility. It was built with private funds. There was never a commitment by Interior Health that it would be supported, and the process that we go through for the new beds is a open and fair process, and unfortunately that particular facility didn't meet up to the standards that we required. Pardon?
What is the number of seniors residing in the boundary area on the waiting list requiring residential complex care?
No, refer to, do you have any idea of that number?
Well, it does vary, and I think currently, probably as of 2 weeks ago, I don't know for today, we probably had about 10 people waiting.
In not just Grand Forks, but in the entire boundary
Yes,
region?
waiting for facility placement within Grand Forks. That could be people from other communities waiting for placement as well.
So that area would be like Beaverdale to Christine Lake?
It's based upon where people wish to be placed in the facility. So we could have people who currently reside in Castlegar wanting to be placed in Grand Forks on that list.
So have we had, how many seniors requiring this kind of care have been relocated outside of our area?
Last year or less?
Yeah, we'll get back to you on that
Okay.
specific
Yeah,
answer.
sure.
You know, again, the issue that's most important is people have the ability to choose where they want to reside in residential care. So someone
We can't hear you back here. These people can't hear you. Your voice is very, very low.
Remember, we're the old parts. We just can't hear you.
I'm just such a calm guy that I'm not.
Maybe
There are
if you
some
stood
chairs
up.
There are some chairs up here, by the way.
Yeah.
There's one too many. I think you should stand up when you speak.
Sure.
Okay.
So again, the issue of available beds, the system is set up such that people have a choice as to where they want to reside in their declining years in residential care. So you could have someone from Kelowna who decides that they want to live here, or from Vancouver. So again, the issue is trying to get people to the first available bed and then their choice. So the opening of the new beds, you will have a complement of beds in this community that's equal to the rest of the Kootenays.
Thank you.
So I think with the question asking about the number of seniors that may have been located outside the area
That's
from,
right.
from local here.
That would prefer to stay local.
Yeah. So okay, one of the things that I'm really proud of working on the senior executive team for the last bunch of years is we have worked to make sure that each community gets the same percentage of beds. We have a formula that we work out for those seniors beds, or what we call residential care beds, per 1,000 population of seniors. And we make sure that when we have funds available, we add to the community that maybe doesn't have that same access. So for a few years, this area was one of the lowest percentage of beds available. Definitely needed to have some money put there. We were able to find the investments, and that's why the new beds came through the RFP process that is very clean and appropriate, right? So that makes us get the bed level up here. There will be some other community that is a little bit lacking in beds. And we're always looking every year, we go through a process of seeing which of the sites that should have those beds increased to give them a little bit better access. So those seniors that are out of your community, some of them may have gone there because that was their preference, and that was Dr. Halpenny's point. You may live here, want to go to Kelowna, or live in Kelowna, want to come here. And then there's those folks who maybe are from Grand Forks area, had to be placed somewhere else because they really needed access to residential. And again, we've got a really appropriate process of getting people back to that first appropriate bed that would be in the area that they need to get back to. So I'm quite proud of the process we've done in terms of getting the residential care beds in a nice even distribution.
Thank you. Home support services have been dramatically reduced. Can you please tell us what the minimum and maximum levels of service are?
No, I don't have an answer for that off the top of my head. I will get back to you on that one as well. The question, can you rephrase that question so that it's not just hours? Are you asking about services?
Home support services
Okay.
have been dramatically reduced.
Yeah, I'm not so sure that they have been dramatically reduced. I'll have to.
Well, they have been in my area because we only have a nurse 2 days a week now, Monday and Friday, so that's a fact.
Okay.
So that would be good for you to check on that, actually.
And see, very often we look at where's your area.
Well, the public health office in Midway operates for Rock Creek, Beaverdale, Carmi, Westbridge, Braggsville, Greenwood, and yeah, we're in a bad way right now.
Okay. And so I'll get back to you about Midway, but overall, again, I'm looking after a big area, so very often we have to look at statistics that even out over a large area, and I'm not so sure that they have decreased, and I think they've actually gone up. So I'll follow up with you on that specifically. Good question.
So if I can just add to Dr. Halpenny's comment, I think,
Stand up.
So there is a difference between home support and home care nursing, and we've actually heard about Midway's home care nursing earlier today from Dr. Daniel out there, so he's actually advocated for that. But I think if we're talking about home support is the other component.
Yes.
So you're referring to home care nursing, and I think we need to look at home support.
Yeah.
there hasn't been a decrease in home support services in the boundary since probably 2000, I think before Interior Health, when there was changes in the government policy around housekeeping services. That's when there were some changes made. The model of care that is being promoted in the province, and certainly within Interior Health, is to actually not have the caps the way we used to have caps on home support service, which was a maximum of 4 hours a day. There is a growing trend to keep people at home and to support them with resources appropriately based on their need. So not everyone is going to get the same level. It is an assessment process.
In my presentation to you at UBCM last September, I told you that my doctor requested me to ask for the return of the 9 acute care beds in Boundary Hospital that are being used for temporary residential care. Once Silver Kettle is operating, will those 9 beds be returned to or used by our doctors, needing them for the seriously ill patients?
Well, I'm going to turn that over to our expert. I'm going to turn that over to Ingrid because we toured those beds today, and it's a perfect site.
So certainly, I mean, with the temporary beds, we actually did change our bed count from 12 to 11. When Silver Kettle opens, we will restore that hallway back to acute care. Our bed count will go back to 12, which has been for 10 years now. Our average occupancy in the 10 years is we occupy 83% of those 12 beds. So the number seems to be pretty close to appropriate with surges that we do know. But what those beds will allow us to do is remove the 4-bed wards and go back to semi-privates and more privates for people's comfort. So yes, those beds by the fall should be back into our operating.
Thank you. Interior Health has dictated that our public health nurses can no longer provide citizens in our community with STD and HIV testing, and that this should be done through an individual's personal doctor. This appears to be a dictate in the IHA area only and is not a Ministry of Health mandate. We only became aware of this decision by accident and are now aware that agencies, program and service providers, as well as the school district were caught off guard by this decision. Please tell us how you engage the public and stakeholders in a dialogue regarding the significant change in the delivery of this service.
I think the first thing that you expect of us is to use our resources as efficiently and effectively as we can. And when we went back and looked, and this has been going on over 2 years where we've been looking at this, we looked at where the testing was being done, and the testing for those particular cases, the majority, by far the majority, were being done in the optic clinic or in physicians' offices. So only 1% of the testing was being done in the public health office. So to use our nurses more efficiently, our public health nurses, we made the decision that we would go the way the public was going, and the public is going either to their physician's offices or to the clinic. So we were trying to make sure that we used our resources appropriately. And when I went back and looked at the statistics last night, again, and really it was only about 1% of the resort of the cases were being done in the public health unit. Yes?
Public health nurse staffs the clinic.
Yes, which is great, because that was one of the issues that we had is people came back to us and said, well, some of the young ladies are reluctant to go to male physicians, and so I was reassured that they were going to the optic clinic. There was only 5 communities in Interior Health where the STI testing was done in the public health units. It was all done outside.
Can you tell us what the costs are to have a public health nurse do this testing, and what the costs are to have a doctor do the testing? What are the savings to the taxpayer?
Yeah, we didn't do it on savings. We didn't do it for a savings perspective, and the costs are the same no matter where the test is done. It's billed, and so the costs are exactly the same no matter where it's done. To the system in general, but what we were trying to do is use the public health nurses more efficiently and effectively. There is a lot of things that public health nurses have the expertise to do, and we wanted them to utilize their expertise to to the maximum. It was not done for cost savings.
Okay, thank you. Mr. Embry, you're going to feel picked on with this question. I'll warn you in advance. We've reviewed the financial statements of IHA for the year ended March 31st, 2011, and request clarification on director remuneration, meeting fees, and expenses. For the year ended March 2011, a total of $297,014 was paid to directors, and that consisted of $92,208 for retainers, $151,559 for meeting fees, and $53,247 for expenses. We understand directors receive a retainer. However, there does not appear to be any consistency between each director, the number of meetings attended, and the per meeting fee received. Can you explain how these fees are determined?
Certainly. The directors receive a payment. The directors receive a payment. Now, you want to find out how they're allocated per director. The directors
not per director. I mean, I've got that breakdown. I know what each director received.
Yeah.
But in addition to your retainer,
yes,
and travel expenses, we can understand that as well. But there's a per meeting fee.
Yes.
And it doesn't appear to be based on any set dollar per month per meeting. It varies. It goes anywhere. Analysis here.
Well, first of our chairs of our committees, we have 4, receive a little more than others because they have to do a lot of prep work. The chair of the board, myself, I get a little more because there's a lot more I have to do in preparation work for meetings and meeting with the minister and whatever. So that's one of the variables.
Okay, because on average, for that year ended, there were 335 meetings in total attended by yourself and the other directors for that $151,559. So it averaged out to about $452 per meeting, which is
I really
how do you get to be a director?
I can't answer you that. One of the things is that there are some meetings take all day, some half a day. It depends, what's happening. There's some that take an hour. Some of our members drive 6 hours, 5 hours to attend a meeting for 2 hours, for instance. So there's a lot
some of us drive in winter conditions to go to a hospital for a half-hour appointment too.
Well, I understand
and we
that.
don't get reimbursed.
Okay, now, but let me tell you, the total budget for what you're talking about is 1/100th of 1% of our total budget. So it isn't a huge burden, but if you need more information than that, I can.
Actually, Jamie can fill us in. The fees are set provincially.
Yeah, we
don't make these up. So Jamie, you can.
Sure. Yeah, and we'll provide the information. There's a Treasury Board directive, so the provincial government sets the rates for all Crown agencies, including health authorities, and pays on a level based on the complexity of the organization. So a small Crown agency would be at a level 1 and receive certain reimbursement right up through health authorities to Crown agencies like BC Hydro. So that's set out in the directive from Treasury Board, which is a public document, which will explain the rationales for how much is paid for how long a meeting is. For a meeting that's 8 hours long, there's reimbursement up to certain amounts. For meetings that are shorter times, there's certain reimbursements, but that's publicly available.
That's publicly available.
I've done an analysis in comparison to the other health authorities in the province, and there just doesn't seem to be any.
Well, first of all, Fraser and Vancouver don't have any.
No, but they do get their per meeting.
They get per meeting.
Mm-hmm.
So I mean, unless there's more in that. And as far as to your question, personally, I have to go to Kamloops for tests too, and I don't get paid. So, I mean, that's a different issue.
Well, I have one question for you. I appreciate the fact that you've allocated 30 minutes to this discussion. But from 1994 to 2010, I had to drive my husband up to 6 times a year, either to Trail or to Kelowna. I drove it all kinds of weather. Why couldn't you come in February? What's the difference between board of directors traveling in the winter and the citizens of Grand Forks traveling that highway in the winter?
I'll answer that actually.
I don't know why.
We have a schedule. Part of this is my fault. My schedule is set up probably 3 or 4 months in advance. I'm in Vancouver very frequently on provincial meetings. I have no trouble driving these roads in the winter. I've done it many, many times. We grew up in Saskatchewan. Not a big deal. So it was a matter of timing. It had nothing to do really with the roads.
Put it in the newspaper that it had to do with the weather and the roads. Where did they get that
If you read the newspaper here in Grand Forks,
The bottom line
you
is,
didn't come because the roads were too icy
Well, I'm here to
and you
tell
were
you.
scared of them.
No, I'm-
No, I have to travel them like this
Sir,
other lady
talk to
said.
the Sir,
And I've traveled them 7 hours to see
Yeah.
a doctor for 10 minutes, and they could have done it at EKG, could have done it right here and transferred it there, but apparently your guys' rules say that the doctor won't get paid unless he sees me physically, okay?
well, we don't pay the doctors, so we don't make those
Well,
rules.
that's the rule.
No, but I don't
I
make
know
those
that's
rules.
the rule.
Sir, I don't make those rules.
Anyway,
I don't pay the
no,
doctor.
I don't either, but I have to pay for it because
Yeah.
that
You know, the issue
7
is now,
hours
sir,
of driving
let-
for
yeah.
10 minutes
Let me
to see
set
a
this-
doctor
let me
is
set
out
this
of the way.
straight. I am the CEO of a rural health authority. I understand the travel issue. I have no trouble traveling in the winter time. I drive to Cranbrook in the winter. That's not an issue for me. As I said, I grew up in Saskatchewan, 40 below weather. So that's not an issue. The issue really was my time.
Well, that
So that-
isn't what it said in the
Well, you know what?
newspaper.
If everything that I
You're
said
not
was,
80
well, okay. So,
and sick.
okay.
Yes.
Saskatchewan's
What do you,
flat.
yeah. What do you want me to do? Apologize? I'm
No,
not-
but we want the
I
record
understand.
set straight.
I understand your issue.
If we could just carry on. I
So,
hear
there you go.
what you're saying and the concerns, and I think we all appreciate that. But time being of the essence, we do have some other
Sure.
things that we want to carry on with. Does the IHA provide team building retreats for their management? If so, what's the cost, how many attend, and how often do these retreats occur?
Yeah, for the very first time last year, we had a team building session for all the managers who report to the VPs. And it was held in Kelowna. It probably was the most productive meeting that any of the people have been at for a long time. People met each other, they talked to each other on the phone, emails. It was a very productive day. The total cost was around $25,000 to $30,000 to bring all these people together. Northern Health does this twice a year. We've only done it once a year, and we're going to continue to do it once a year for sure, because there's nothing like team building to bring people together to understand each other's issues.
Is any part of the salaries paid to IHA management based on performance-driven criteria?
The salary is not based on performance driven. We have a what's called EPM, which is Employee Performance Management, and it's like any other corporation. If someone isn't doing well, we will obviously hold their salary at one level. If someone is improving, then there's a grid that's set up, and again, this is a provincial grid. We can't do any of these payments outside of provincial policies, but it's not set out such that at the start of the year, the person says, if I do this, this, and this, I will get a certain amount of money in the grid. So it's not a real incentive, it's a performance management.
So if someone, do you set goals and objectives?
Absolutely.
So that if you don't achieve that, is part of your salary withheld then?
No. I'm the only one in the province whose salary is withheld.
Oh.
10% of my salary is withheld.
Okay. Thank you.
I know what you're going to ask me.
We are concerned about quality control in meals prepared in Vernon. Pardon me.
I'm ready for this one.
You've heard it before. Truck to Grand Forks and reheated and then served to the patient. We are advised by those who have tried to eat them that they are very unappetizing. In fact, an elderly friend of mine, now deceased, asked to go home as she was not able to tolerate this food. We are also concerned regarding the cleanliness of laundry trucks and Nelson for laundry.
One at a time.
Okay.
There are two questions. So we have 4 cooks here, I think it's 4, and the majority of the food produced here is produced locally. We had the meal today that was served to the staff, all of us, and I'm sure, and to the patients. It was not freeze-frozen. We occasionally will do that, and it's rare. So the majority of food that's eaten in this facility is produced locally. Geez, I thought you were bringing that to me.
She's asking questions. All the way from Vernon.
So I was really impressed. I was really impressed with the food today.
So there's not that much that's being served that's fresh flash frozen. Okay.
What components are comprised at Vernon that are this way? Your meal.
The majority, by
The majority. I don't know what majority is. I don't eat it.
Okay.
And what specific items are processed in Vernon?
Oh, they're whole meals, and the process that we have in Vernon and Penticton is really quite fantastic. What we did is
What are they?
Well, it's a full meal, and so it could be potatoes, it could be peas, it could be carrots, it could be meat, it could be chicken. It's a full meal, and we use those for Meals on Wheels in many locations.
And that's taking local jobs away.
No.
Why
No, it's
don't
not.
we have it in Grand Forks? Why do we have to go out of the town?
No, you don't, though. I'm saying that I would say 95% of your meals are produced here. And only when situations arise, we bring in something from Vernon. So
there's four jobs.
There's 4 jobs here.
There's 4 certified cooks here, plus support workers.
Okay, so how long has that been happening?
What situations?
For example, if there was a supply issue with the delivery of different types of products, those are the types of things that would drive us to say, we have to make sure we have to feed people. And I can assure you that the food, although some people say it's not palatable, it is the most nutritious way of producing flash frozen foods.
Are those foods microwaved when they get here?
No, there's a special heating process that's not microwave, it's convection.
Oh,
And they're flash frozen such that, and we actually did studies on this, they're flash frozen such that the temperature goes down really quickly and the nutrients stay in the food.
Okay. The other half you've heard too, and that's with respect to the laundry and the having it trucked to Nelson for laundry and then returned. I'm told wrinkled with mold deposits, threadbare, and below the standard which should be expected. So, is there any consideration to bringing that service back in-house?
I would say no. The service I haven't heard that complaint of threadbare or mold. The laundry in Nelson, and correct me on the numbers, but it supplies about 226 beds across all of Interior Health, and we only have 1,200 beds, so it supplies about 1/6 of our beds. So it's become a real nidus for not only Kootenays, but East Kootenays as well.
Gondry Hospital has an operating room that was renovated extensively within the last 10 years or so. We hear on the news fairly regularly surgeons commenting about the lack of operating room time. What is the possibility of a surgeon coming to Grand Forks and utilizing our operating room in the hospital for procedures such as colonoscopies or D&C?
It's my understanding that you're already starting to do some of those minor procedures. No?
Just consult.
Just consult.
That's what surgeons come here, right?
Yeah, the surgeons do come here to consult. But it's, yeah.
So could they not utilize the operating room then to do some of these minor procedures rather than having to go to Trail or Kelowna or wherever?
So we've explored that. Certainly with the surgeons coming from Trail, so we actually have an orthopedic surgeon who comes to the community roughly once a month, sometimes once every 3 weeks, and sees roughly 40 to 45 patients in that one day that he's here. He does do a few very minor procedures, but there is a concern that, again, if there is a problem, that we don't have the backup to be able to provide safe care. We have 2 general surgeons who come here, and they come roughly about one a month. And again, they prefer to do consults because there is a concern that if you don't have the capability to actually deal with a complication, that you're putting people at risk. We actually have the gynecologists from Trail. They come less often, but they come about 5 times a year. And they do, and we have pediatrics now that comes, and we have psychiatry that comes. So we've been really trying to maximize their time when they come, because if they do 2 or 3 procedures only here, and 25 people still have to travel to Trail, that's not very productive. We've already heard your comments about traveling for attending an appointment. That's why we've actively been trying to get the surgeons to come to our community and actually see pre-op, post-op, and try to reduce those things. For the fellow that talked about the ECG, we're actually actively working on that piece right now to see about pacemakers and those other pieces to reduce your travel again.
Well, I understand that like EKG can be transferred from here already.
It can now, yep.
Yeah.
It can now.
Well, it could when I had my problem too. But they just didn't do that.
So we are working on, filling those issues, but certainly some of it is the surgeons who really are concerned about the complications that they try to do procedures.
So are there a number of instances, because it hasn't been that long, like I worked with Mary when she was here, and she used to assist in hernia operations. Were there a lot of times when they had complications? A lot of instances of that before when they were using the operating room?
So the general surgeons who've been traveling from Trail were not the ones doing the hernia. It was actually some of our own physicians who were doing that. And again, because they're only doing 1, 2, 10 a year, the concern, which you're likely going to raise as you on one of your next questions, probably about maternity, the concern was not about the budget. It's around maintaining skills of those physicians and nurses to safely manage not the routine, but the complication. And because at that point, it's too late to deal with it.
Christine, we're running over.
Yeah, I can't, just one quickly, if we could
Please.
just deal with it, and then, municipalities like Grand Forks have a hospital. Citizens are concerned that they have no opportunity to comment on changes affecting their health care. Would you consider implementing a local advisory panel that would include members from all areas served by the local hospital?
And this is one of the things that we talked about with the local elected officials, and we're trying to set up a system. Ingrid has been our point person here, and we'll look at setting up a system where we can have local community folks funneling through their elected folks and through to us.
Well, having been an elected folk, I had heard that you were asking local governments to filter the complaints, and I commented to our mayor, I wouldn't touch that with a 10-foot pole, because you're dealing with people are going to be dealing with front-end staff. They're not necessarily going to be going to the elected official, and that's going to put a real terrible burden on the people. What we're proposing is that we meet by video conference, so that if people have concerns, they can
very often those local concerns should be directed through to Ingrid. She's the one
Ingrid
that
isn't in a position, with respect, and no offense to you, Ingrid, to make any decisions. In that respect, I don't think you report directly to Dr. Halpern or Mr. Ever. You report to the Vice President of Care, right? So what?
See, the structure is set up. As a CEO, I have a number of VPs, and I delegate the responsibility to each one of those VPs. I don't make every decision, and we try to make decisions collaboratively across the senior executive. So,
then having heard that, would you still be supportive of having an advisory panel that could meet with Ingrid and by video conferencing with the Vice President and bypass the elected officials?
Yeah, I wouldn't make a comment on that because we have a responsibility to work with our elected officials. So let's carry that conversation on later.
Okay.
We're just about done, so
Just quickly,
I want to finish off with.
when you talk about the elected officials, we're always told they're there to deal with financial matters.
Mm-hmm.
And so, unless it's a financial matter, what is the point of dealing with the elected official? I mean, it seems like there isn't an avenue for concerns outside of financial issues. So
Okay.
how do we deal with that?
Yeah, and again, Ingrid's the point person that we have for this area. I would suggest that the communication go through her. But let me just kind of give kind of a different side of the story here. I'm a physician. I practiced family practice for a number of years, in the same position as Jeff has been, and then got into administration. So when I look at these issues and look at communities, I look at it from a physician's perspective, not a business person's perspective. When I come to different communities, I can tell right away by meeting with the staff and the physicians what the quality is going to be like. I don't have to go to my quality reports and look at mortality rates and whatever. I just have this intuition because of the people who are working there and the teamwork in that community. You folks have probably one of the best hospitals in interior health for the size. And the reason for that is you've got medical leadership, you've got a group of physicians who are cohesive, they work together, they split up the work such that they take call. At one time there was only 6 physicians here, and I had another community who had 14 physicians who they refused to take call. So you've got clinicians here who do cancer, who do renal, who do cardiac. This is different than a lot of other communities. When I meet the staff, I can tell right away whether or not it's a cohesive staff. All you have to do is walk through this facility and someone will actually look at you in the face and say hi and smile. You have no idea what that's like in other communities where you don't have this cohesive unit. The other part about where we're going in interior health is the telehealth that we do in interior health is top-notch in the country. Our thoracic telehealth, people don't have to travel after they're having their lung operated on. We now have a cardiac center in Kelowna where people previously had to go to the coast, and 12% of the people right now of that program are coming from this area. For every 100 people that go there, we save 9 lives. So there is so much positive going on that you don't see. And I'm actually proud to come into this facility and see the people who work there and the work that they do. So that's accentuate the positives of healthcare rather than negatives.
Thank you. Thank you all. We'll get back to you with some of the questions we didn't have.
Sorry. No, that's fine.
There is a lot of public access to information, as you all know, and I look forward to meeting some of you maybe during the winter sometime. Thank you. Thank you all. Be healthy. Be happy.
Well, there you have it. The IHA came to town. You just heard them. You saw them. The questions, the answers, what do you think? It's your health. It's your hospitals. When you get sick, when you get too old, be able to take care of yourself, what's going to happen to you? Do you like what you heard or don't you? Check the local media, and by all means, with the local media stories on this, you can contribute by commenting on those issues that you found you want to talk about. Comment on their comment boards. For GFTV, I'm Les. We'll try and bring you more as it happens.